Acute-on-Chronic liver failure, ACLF, a serious but potentially reversible condition in patients with chronic liver disease and cirrhosis, has high short-term mortality within 28 days. Many patients with ACLF are hospitalized in an intensive care unit due to multiple organ failure. To date, there is no approved treatment available, and liver transplant remains the only cure. ACLF represents a high unmet medical need and a significant economic burden for healthcare systems. Hepatocytes, the primary liver cells, are the target of most harmful processes resulting from different underlying chronic conditions. When damaged, they release pro-inflammatory signals and fibrosis mediators that stimulate collagen production by myofibroblasts, causing liver scarring called fibrosis, and ultimately liver cirrhosis. Initially, cirrhosis may be compensated, a state where the liver is irreversibly damaged but may still function adequately. Over time, cirrhosis can lead to increased resistance to blood flow through the liver, impaired gut barrier with increased risk of bacterial translocation, and reduced liver function. This may result in complications known as decompensated cirrhosis, such as accumulation of fluid in the abdomen called ascites, gastrointestinal bleeding, or impaired brain function. This condition is associated with an increased risk of developing ACLF. What triggers ACLF and multi-organ failure in patients with decompensated cirrhosis? Liver function and the function of other organs can rapidly deteriorate following precipitating factors such as bacterial infection, alcohol intake, and others. ACLF is the result of acute and pronounced systemic inflammation, organ hypoperfusion, and cell energy depletion. It is characterized by dysfunction and failure of the liver and multiple other organs. The organs predominantly affected are the kidneys and the brain. Promoted by reduced blood flow, more than 2/3 of patients with ACLF are concerned with kidney dysfunction or failure. The accumulation of inflammatory mediators in the blood, such as ammonia, can lead to impaired brain function. This condition is called hepatic encephalopathy and impacts up to 60% of patients with ACLF. Reduced blood flow throughout the body and systemic inflammatory processes may ultimately lead to circulatory failure. The lungs can also be affected and may ultimately require support with mechanical ventilation. The number of organ failures define the grade of disease and prognosis, with a greater number of organ failures linked to higher mortality risk. For a patient with ACLF admitted into an intensive care unit, the odds of recovering and being discharged are approximately 1 out of 2. Therapeutic assets in our pipeline target complementary pathways, leveraging different modes of action and administration, offering hope for better outcomes. Liposomal technology VS01, administered via the peritoneal route, aims to clear ACLF-related mediators, including ammonia, liver and kidney toxins, as well as bacterial-derived endotoxins. Nitazoxanide, administered orally, aims to impede bacterial translocation from the gut and block hyperinflammatory responses. ASK1 inhibitor SRT-015, an injectable agent, aims to block cell death, inflammation, and fibrosis. CLM-022, an inhibitor of NLRP3 inflammasome, aims to prevent inflammation and cell death. VS02, an inhibitor of urease to be administered orally, aims to reduce hyperammonemia and prevent hepatic encephalopathy.